So today we are looking at a plausible long case. This clinical vignette is actually about a 42-year-old woman, comes with 8 weeks of non-bloody diarrhea, weight loss, nocturnal symptoms, iron deficiency, and she has already underwent a colonoscopy as well. The colonoscopy shows no normal findings, and as I said, the duration has been around 8 weeks of duration. But disregarding the question and the MCQ that I have already posted, we'll take this as a long case. Now, assume that this patient comes to you saying about diarrhea which has been there for 8 weeks duration. So, what is the what is the definition of chronic diarrhea? It is actually more than that of 4 weeks, and with adequate stool volume as well. And then during your evaluation, what you have to do is you have to take out the history to evaluate and find the possible differential diagnosis and take them out. In the long case, what happens eventually is that you will be asked about the investigations that you have to do and then come to a conclusion, and finally they'll go along a pathway asking about management. So we'll try to evaluate this chronic diarrhea in a way that we can come to a differential diagnosis. Later, I'll discuss about the MCQ as well. Right. So, now the first question that you should be asking is to characterize the diarrhea. The characterization includes few questions. This, of course, now to characterize the diarrhea. Diarrhea. So, some questions that you should be asking is duration. Now, as I said, it is more than that 4 weeks, so we can take it as a chronic diarrhea. And the frequency, the volume. So these are few questions that need emphasis. So volume and the consistency of the stool. It could be mucoid, it could be watery, it could contain blood stains, or it could be even blood as well. So consistency. And uh, you have to distinguish, as I said about consistency, a key feature is that you need to distinguish between the possibility of watery diarrhea from fatty diarrhea. Now, first, I'll go ahead with fatty diarrhea. This fatty diarrhea implies the fact that it could be, the term that we use is steatorrhea. What is steatorrhea? Steatorrhea is bulky, bulky, uh, pale, and stools that are somewhat difficult to flush. Floating stools consisting of oily content. So those are some characteristic features that you see in steatorrhea. Now, in such cases, if you see this steatorrhea from you know that there is fat in the stool content. So if there is fat, then go back to your pathophysiology and ask yourself why there is fat. So the main enzyme that is involved in digestion and absorption of fat is lipase. So there has to be some sort of an issue which might have an effect on the pancreas. So this could be not acute pancreatitis but chronic pancreatitis. So male coming in their 40s, 50s who has been a chronic alcohol user and using as an eye opener. So then there is potential that this could be chronic pancreatitis. So that is number one. Chronic pancreatitis. In chronic pancreatitis, what you can do now, I'll go through the investigations as I say this. So, what you can do a simple amylase test, serum lipase, and even urine lipase to identify chronic pancreatitis. Sometimes the serum amylase might not be positive. It could be negative as well, but it will not show high value as that of acute pancreatitis. What is the value that you see in acute pancreatitis? It is more 3 times more than that of the upper margin. So that is not that. So amylase, lipase, and even urine lipase. Simple other test that you can do is an X-ray abdomen. You would see calcifications in the X-ray. So X-ray, serum, amylase, and urine lipase. So these are some things that you can use to identify chronic pancreatitis. What else? Now there could be actual plausibility that this might have something to do with the bile. If it is the bile that is involved, sometimes there could be some sort of a blockade which might prevent the bile from flowing into the lumen, or else it could be another problem where there is this the bile is not absorbed. So it could be bile malabsorption cause. So I'll come to this as I go on. So now again, steatoria. Now you have come to somewhat a good conclusion, and then with frequency, volume, and consistency, another key thing that you should be asking is whether this patient is having any constitutional symptoms. Any constitutional symptoms? What are constitutional symptoms? It could be loss of appetite, loss of weight, and sometimes these patients come and say about tenesmus and incomplete evacuation sensation, where you pass those, but still you have this sensation to pass more as well. The second would be spurious diarrhea. What is spurious diarrhea? Now there is this normal sensation. You get it early in the morning, and then you pass out explosive form of a diarrhea with sometimes the passage of blood. So that again is problematic. Then in such case, and even sometimes this could have urgency as well. So these symptoms are somewhat suggestive of a malignancy, colonic carcinoma. So there are two major areas where you get colonic carcinoma. One could be in the sigmoid 70% of the time, or else it could be in the celiac, in the cecum, which is around 30% of the time. The cecum usually does have very insidious findings and sometimes present to the clinic with anemia, only with anemia. So colonic carcinoma. What about colonic carcinoma? Now, in the history, you should be asking about the of family history as well. There are some syndromes which are associated with a higher pinch on getting colonic carcinoma, such as FAP, which is familial adenomatous polyposis, and HNPC, PCC, which is hereditary non-polyposis colonic carcinoma. And again, if it's a must, you should ask about some possibilities of endometrial carcinoma, family histories of breast carcinoma, because they have their associations with colonic carcinoma. So that is one thing that you should be asking about the constitutional symptoms. Now, what else? So, is colonic carcinoma the only possibility? No, there are a few others as well. So, there could be some cancers that are related to the small intestine, such as that of lymphoma. If you can remember, now there are patients who have celiac disorders. Celiac disorder, you get a possibility of converting that into a lymphoma. So most of them come with these B symptoms, pruritus, loss of weight, and constitutional symptoms. So B symptoms, you should know what B symptoms are. Right. So lymphoma is the other possibility. Are there any more? Yes. Neuroendocrine tumors, very rare, but still that is a possibility. Neuroendocrine tumors. What are the neuroendocrine tumors that you can come across? One thing would be the, the Zollinger-Ellison syndrome, where you get multiple duodenal ulcers because of the hyperactivity of the G cells producing extra amount of gastrin. So there is such production of gastric juice where it eat into diarrhea. What is new? There is something called VIPoma. Now, these are some basic physiology. If you can remember, VIPoma, again, you get these in the pancreas and sometimes in the small intestines, where this VIPoma starts producing VIP, vasoactive intestinal peptides. This increase the motility of the gut, thereby leading into diarrhea. So, VIPoma, you have to look for the serum levels of VIP. And then what else? It could also be carcinoid syndrome. But in a carcinoid syndrome, you get excessive levels of serotonin, carcinoid, flushing, and flushed. You get a flushed appearance, and also there is this steatorrhea. Sometimes even cyanosis is possible. So you have to ask that as well. So these are some malignant possibilities. Now, what else? There are a few more as well. You have to take the drug history. The drug history now, a very common thing that we see in the wards, which would be antibiotic mediated. Once you have given antibiotics for a long period, but this usually does not come as chronic diarrhea, but again that's a possibility. So antibiotic mediated diarrhea, you have been using few antibiotics for a long period of time. Now it has actually disrupted the bioma of the gut, and some of the opportunistic infections has now set in as well, and the normal homeostasis of the colonic region is somewhat disrupted, and hence you get diarrhea. So drugs, antibiotics, what else? Now there are some other drugs that you are using in the function of passing stools to aid defecation, such as laxatives. If you can remember, if you can remember the pharmacological lesson that were given to you, there are multiple types of laxative. There's bulk forming ones and there are secretory ones, osmotic ones. But all these laxatives has the possibility to cause, if you are misusing them as well. Now, there are some certain cases in psychiatry. There are these body dysmorphism syndromes, and there is anorexia nervosa, and there is also anorexia bulimia. So in certain cases, you get these laxative abuses just to pass the content that you consume, so that you become thin. And so in such cases, it again leads to chronic diarrhea. Now, if you abuse lactulose, which is a common laxative that we give in the wards, there is something called, you get this dark colored pigmentation in the colon. Whenever you do a colonoscopy, you get this dark colored pigmentation. It is known as melanosis coli. Right? Make sure that you Google the picture, because sometimes it might come in a picture test as well. So melanosis coli. And what else? Now, there are these other drugs. If you use that for a long period of time, there is this possibility it might lead to diarrhea, such as SSRI, selective serotonin reuptake inhibitors. What else? NSAIDs, such as colchicine, proton pump inhibitors. Now, you have come across in my clinic days. I see so much of people coming with pantoprazole and omeprazole and whatnot has been used for more than that of 2 months or 3 months. So they have this potential where there might be lymphocytic infiltrations into the colonic mucosa, leading to something called microscopic colitis and inflammation. Microscopic colitis. How do you investigate mitochondrial curiosity? Whenever you come across this, you it's a normal colonoscopy. It's always a normal colonoscopy, but even in a normal colonoscopy, if you are having diarrhea and it is chronic diarrhea, then you have to take biopsies to rule out the possibility of a microscopic colitis. You have to take biopsies in the sigmoid and even in the transverse or the cecum as well. So what is again a very common drug that can cause diarrhea is metformin. Metformin. And another drug that we see is uh, antacids, magnesium containing and antacids, milk of magnesia. Yeah, and sometimes there is this immunotherapy drugs that we are using for in terms of cancer treatment. This has a possibility of leading into diarrhea. So those are few. Right. What else? Right. So then again, ask about the dietary history, which is a must. Dietary history. Ask about the possibilities of artificial sweeteners such as sorbitol, mannitol that they have been using, or caffeine, and even alcohol, which is an important thing, and sometimes even herbal supplements that you usually come across. Now, one of the most critical areas that I have not touched is the possibility of an infection. Now, there could be there are certain parasitic infections. Again, do a stool field report. Stool microscopic evaluation is required. You have to look for ova and certain parasites as well. There are few parasites that need to be entertained in circumstances of chronic diarrhea, such as giardiasis and even strongyloides. So these are some parasitic infections. Then there could be fungal and bacterial infections. Chronic diarrhea is somewhat you don't see it in this E. coli and these other forms, but there are these other in circumstances when there is immunosuppression, such as in HIV patients. In such instances, there is this possibility that it could have infections such as cryptosporidiosis, isosporabelli, and even cytomegalovirus, which might so again viral disease as well. So cytomegalovirus, cryptosporidiosis, and so these are few cyclosporiasis. So these are few infections that can lead to chronic diarrhea, and of course TB, intestinal TB. You have to think about that as well. Intestinal TB sometimes it warrants an IGRA study to identify latent TB. Sometimes a colonoscopical biopsy may you might see that, and you might see certain caseating granulomas. Even in sometimes enterograms and CTs, this could be identified. Usually, intestinal TB may have peritoneal adhesions as well, so leading to sometimes uh, these disruption in bowel motility and stasis. So those are few infections that need to be entertained. What else? The other thing would be endocrinal issues, a very common condition that lead to persistent diarrhea with increased appetite. However, loss of weight and increased pulse rate would be hyperthyroidism. Hyperthyroidism. And the other thing would be diabetes. In diabetes, you get a secretory diarrhea, and you get this alongside with that you get peripheral neuropathy as well, and vomiting. Again, another association that you see, and this is a secretory sort of a diarrhea. So diabetes mellitus. And there are autoimmune disorders and now another important thing is we ask the patient whether he has underwent any previous radiotherapy. So in radiotherapy, any ileal resections, any previous surgeries, so cholecystectomy. So these might have issues with diarrhea, right? So in, despite all these possibilities, the other important question that you should be asking is familial history. In the familial history, the patient might get, there might, these are the most important ones. In fact, there is a possibility it could be inflammatory bowel disease. Now, I'll go to a separate question, uh, comparing and contrasting between ulcerative colitis and Crohn's disease. So, in the family history, ask about these. Look for extraintestinal manifestations, such as there could be a peripheral arthropathy, clubbing, whititis, eye signs, and there is this also this possibility there might be certain skin manifestations, any pyoderma gangrenosum like manifestations, and also skin nodules, and may have a history of ureteric calculi because this of the disruption of the oxalic acid, increased oxalic acid absorption. So these are few things that you need to understand, and also perineal lumps, perianal perianal abscesses. So these are again few other extra intestinal manifestations that you get in IBD. Some are more prominent in Crohn's than ulcerative colitis, and vice versa. But this is a later topic, and I'll go through that as well. Number two would be celiac disease. Again, a very important topic. We'll learn in a more comprehensive manner in another day. So family history is important as well. The complications are further important. Now I will not go into the complications at the moment and the investigations. For investigations per se, we'll go to them. We'll try to emphasize on these facts in a later day once we have more time, right? So again, as I said, in the long cases, these are some differential diagnoses that you need to comprehend and ask for and evaluate. So there are other investigations. These investigations, now there could be nutritional problems. You have to think about both micronutrient and what do you call this, macronutrient problems, and also you have to do baseline investigations such as full blood counts, ESR, CRPs, and in addition to that, you have to think about these endocrinal issues. Then you have to do thyroid profiles, and if it's a pancreas that you are thinking about, then you have to think about HbA1c or fasting blood sugars. And if it is something to do with celiac disease, you have to think about other important nutritional deficiencies such as iron deficiency, vitamin B12 deficiency, ferritin levels has to be done. If it's an infection, you have to think about stool microscopies, and also stool full reports, culturings, and HIV. You have to take out the possibilities of immunosuppression, retroviral stress, and in celiac you have to do IgA levels, transglutaminase anti-tissue antibodies. So these are things, these are some investigations that you need to do. But however, I'll not go into them at the moment. In IBD, there's called fecal calprotectin. So all of these are there, but I'll not go into that. And finally, colonoscopy. We'll continue with MCQ. Right. So the first one. Microscopic colitis often has a completely normal macroscopic appearance. Yes, that is true. As I said, most of the time in a microscopic colitis, you have to think about an elderly woman who comes to your clinic who has been using proton pump inhibitors, NSAIDs, and sometimes a depressed woman who has been taking SSRIs. So the use of the utility of these drugs on a long period of time has a potential to cause microscopic colitis. There is another entity called lymphocytic colitis. You should at um, at the final year level, it is not for a greater say it is not that important, but still there is this obvious differentiation between lymphocytic colitis and microscopic colitis. Somewhat different. It is dependent on the lymphocytic count and the lymphocytic infiltration degree. So the macroscopic appearance of the colonoscopy is somewhat normal. It is, you don't see any deformity as such, but you have to take biopsies. The biopsies will show you biopsies would show that it is a it is a microscopic colitis. So the statement showed a normal colonoscopy effectively excludes the microscopic colitis, making random colonic biopsies unnecessary is a false statement. Statement B. Persistent diarrhea associated with flushing, bronchospasms, and right-sided valvular heart disease should prompt measurements of 24-hour urinary. This is 5-hydroxy-indole acetic acid. Again, as I said, carcinoid syndrome. There is this hypersecretion of serotonin. Serotonin leading to serotonin is a vasoactive peptide which can cause dilation of the vessels. So flushing and dilation of the smooth muscle cells. So bronchospasms, dilation and sometimes even spasms. So bronchospasms, and it has its action on the right side of the heart as well. So in such conditions, you have to think about. So in a nutshell, you have to think about the possibility of carcinoid syndrome. Along with that, keep in the mind that it could also be some other endocrinal issues, which could be a VIPoma, which could be Soling-Ellison syndrome, or it could be the possibility of a hyperthyroidism. So this is carcinoid syndrome. As I said, right-sided valvular involvement, tricapsid, and pulmonary fibrosis is very common when you consider carcinoid syndrome. Statement C. Persistent diarrhea in a patient with diabetes mellitus and autonomic neuropathy is usually osmotic and typically resolves with fasting. Now, a common characteristic feature that you see in new diabetic diarrhea, I'll use that term. Diabetic diarrhea is the nocturnal symptom. You get nocturnal diarrhea. This usually occurs in patients where they have been having this diabetes for a very long period of time. It has been of poor control. There is already neuropathic conditions that have been set in. So in such cases, it is not, even though you fast, it will not have an effect because this is a secreted diarrhea, because there is this secretion of um, fluids into the lumen from the blood vessels, which will cause the loss of stools. Hence, even though if you don't take anything into your system, which means into the GI system, it will not have an effect. Fasting will not settle the diarrhea that you get in diabetes. So it's a false statement. Okay, statement D. In patients with persistent diarrhea, weight loss, recurrent oral ulcers, and venous thrombosis, Behcet disease should be included in the differential diagnosis. Yes, Behcet is a vasculitis. At this moment, I don't think that Behcet's will come to your examination, but again, you should have a bit of an open mind to this. So, if there's this triad that you see in Behcet's disease, which includes oral ulcers, genital ulcers, uveitis. It can have multiple systemic effects, which one would be the possibility of getting these ulcers in the ulcers in the colon. Again, if you can remember, when you say about ulcers, you think about Crohn's, but it is not similar to that of Crohn's, because in Crohn's you get these sort of a longitudinal ulcer, but in Behcet's you get a punched out ulcer. It's very problematic as well. It's very deep and it's problematic. It can cause abscesses, and also there is this possibility of perforation. So Behcet's common triad that you need to remember is the oral ulcer, genital ulcers, and the uveitis. It is associated with thrombosis as well. So, statement B. Persistent diarrhea with negative celiac serology completely excludes celiac disease. Celiac disease. I'll do a separate class, as I said, on inflammatory bowel diseases as well as celiac disease. In celiac disease, few things that you need to understand. The problem is for the now celiac disease. There is inflammation of gut wall because of the presence of a simple protein known as gluten. Gluten is seen in wheat, is seen in barley, rye, and uh, many other the food that you consume. So, in this case, in celiac disease, you get multiple systemic involvement. Uh, of course, it is the characteristic feature is that you get these active CD4 cells, which starts ruining the gut wall. There is associated cytokine as well. So B cell activity, T cell activity, and cytokine release, which can cause gut wall inflammation. So what it causes is, now initially it causes crypt hyperplasia. Crypts become larger. There's a crypt hyperplasia, and then later you get partial, and at a certain time you get subtotal, and then at a certain time you get total villus atrophy. Once the villus get atrophied, absorption becomes somewhat difficult. Then at a very later stage you get hyperplastic mucosa. It thins out. The wall thins out. So these are few stages you see in celiac disease. The staging is this is not relevant to you. It comes due to medical registrars possibly, but there is a classification system for staging which is known as Marsh classification. Marsh classification, not necessarily. Right. So the most classical symptoms that you usually encounter is the steatorrhea. They say about weight loss. There is this always the abdominal pain, and in children, once they are weaned off and they have this potential to go for failure to thrive, FTT. So again, should have an open eye when it comes to failure to thrive in pediatric population. Earlier, celiac disease was not very common in Sri Lanka, but now there's a little bit of a preponderance. There's a little bit of a prevalence which has been rising these days, right? So, what are the complications? The complications involves iron deficiency anemia. As I said, it's the most common one. Then vitamin B6 and folate, vitamin B6, B9, not much of B6, but B9, folate deficiency, and B12 deficiency leading to neuropathy. So there is this peripheral neuropathy that you get, and sometimes even ataxia. Peripheral neuropathy. This actually came to us as ataxia and celiac disease, B12 deficiency, ataxia, subacute combined degeneration came to us as a essay question in our final. So, and also because there is a possibility of low vitamin D levels, vitamin D deficiency, and calcium levels. So the micronutrient deficiency is somewhat very prominent in celiac disease. And in addition to that, you might also get these uh, infertility, subfertility, and miscarriages. So there is this association. A very common skin manifestation would be dermatitis herpetiformis. I'll upload a collection of photos showing the complications of celiac disease as well. So this is dermatitis herpetiformis. Very, it's a maculopapular sort of a rash that you get usually in the elbows, the knees, and the buttocks. It is very itching as well. So it's very common association. And in addition to that, it has its uh, attributes in the hepatic tissue as well, will lead into transaminitis, which means AST/ALT will be high, and sometimes there would be a possibility of primary biliary cirrhosis as well. So it's a common association. And celiac disease tend to have association with other autoimmune disorders, which lead to autoimmune thyroiditis, pernicious anemia, and so these are other possibilities. Autoimmune hepatitis as well. Right. Another common symptom, a sign that we see is the angular stomatitis, because now iron deficiency is somewhat very prominent. Right. How do you investigate for celiac disease? What you can do is you do now in the this is a disease that is associated with the gut system. In the gut, you get antibodies. The most common antibody that you see is the IgA. So you would do a IgA level, total IgA level, IgA total level, and transglutaminase level, anti-transglutaminase antibody. So if there is anti-transglutaminase antibody, you know that this is if it's a celiac disease that you're looking at. But there is this 10% of the time where IgA levels are low. That's why we need a total IgA level as well to identify that there is IgA deficiency. So in such cases, you have to think about in that case you have to do a IgG anti-transglutaminase antibody level. Sometimes these days we do not do gliadin peptide, but earlier IgG deaminated gliadin peptide was also done. Right. Uh, the genetic association is again, this comes in MCQs, HLA DQ2O8. Right. So what you can do for now after doing the antibody levels, what you can do is you can do a duodenoscopy, and from the duodenoscopy you have to take a biopsy. In the biopsy, you will identify that there is villus atrophy and can do a Marshall classification to classify the disease as well. So celiac disease could be the identification or the confirmation of the diagnosis is through duodenoscopy and biopsy, not with antibodies. Right. There are a few others as well you need to, when I say celiac, villus atrophy. Villus atrophy is also associated with few other conditions. Again, I'm not going into the details, but you have to know that there's something called Whipple's disease, an infection, and there is also called tropical sprue disease. So these are a few other conditions that lead to villus atrophy, such and also giardiasis as well. So yes, persistent diarrhea with negative celiac serology completely excludes celiac disease is not correct because of the fact that most of the time, or not most of the time, there is a possibility that they could be IgA deficient. In such cases, you have to do a IgG based transglutaminase antibody level, and sometimes even the confirmation per se, you have to do a duodenal biopsy. Right. The most common problems with celiac disease is the failure to thrive in children, and also the iron deficiency, as well as the itchy rash that you get, which is known as dermatitis herpetiformis. So yeah, this is it. We have gone through the conditions, and yeah, for the celiac disease, I'll upload this picture. So there are multiple problems that is associated with celiac disease. I'll go through this once I have a time, and perhaps in another lesson. Right. So we'll meet with the next lesson, uh, possibly within this week. Thank you.